are working on. And I want to begin with Edith from SEHAD to share insights briefly.
Good afternoon, everyone. Thank you, Karim, for handling this session since morning, and also I'd like to appreciate the previous speakers for what they have shared. So the question is, how do we ensure that community financing is enhanced? One of the things, I'll share an experience as the Center for Health, Human Rights and Development in our community engagements that we do that always lead us at the national level advocacy. So one of the things that we do is we identify different stakeholders that are relevant, that are key to ensuring improved health, mainly at the community level. Because most times we think that to improve health, we only need finances all the time. We need the money, we need the cash that most times is not there. So we have tried to invest in what we call social financing strategies, where we use the locally available resources to be able to improve service delivery. And how do we do that? One of the things that we identify those key stakeholders in health governance. For example, we've been talking about the health unit management committees. These are very key in managing the health facility and ensuring that we improve service delivery. Then we look at the village health teams, then we work with the district health teams. We conduct a lot of capacity strengthening on issues of governance, decision making, community participation, budget advocacy processes, and then in the end, these people get to know what their roles are and how they can support the different health facilities to be able to improve service delivery. And we have seen that because of this capacity strengthening, the services have improved, and some health facilities are reporting an increment in the primary health care fund that is given to them. There is out-based financing that is being given to them on a quarterly basis or an annual basis, just because of a change in the governance at the health facility or the systems that they are now using and implementing. And on that same issue, we usually also talk about involvement of other stakeholders, especially the local organizations, because they know these health facilities, they know the community, they know the dynamics of those different communities. So we engage them in most of these engagements, and then they are able to advocate for improved financing at the health facilities. And we have seen that some health facilities have established youth corners without any money, just reserving a room, and then they start giving youth responsive services, which was not there before. And then some of them have included young people on the health unit management committees, because when you look at our guidelines for the health unit management committees, most of them are mature people, and we don't have an allowance for young people. So you see that when we look at only the old people, we are leaving out a special category of young people within the community. So through our different engagements, we are seeing that now we are also having young people as part of the health unit management committees, and they are participating in the different advocacy engagements. Then another issue that we are really focusing on is majorly around establishing and participating in feedback mechanisms and platforms. Yes, we do the trainings, we engage the health workers, the HUMICs, but when do we get to hear from those people? So through these different feedback platforms, we get to hear information from these people, and then we engage the duty bearers, because usually these feedback mechanisms, we have the duty bearers as part of the feedback mechanisms, and then they are able to support what is happening within the community. And since morning we've been talking about the DICAs and the relevance of these DICAs, and we are going to launch them in the pre-adolescent conference next week on Monday. So that means that is one of the feedback mechanisms that we are looking at district level. We have different working groups at a different level. I mean at district level, but also at national level. For example, we have district health committees that usually sit on a monthly basis. We try to engage and also involve health workers to give their feedback. When we come to national level, we've all heard about the LMNS, the local maternal and neonatal structure, where we are having feedback, and that is helping us to give an accountability on maternal health. And that means when we have an accountability platform, we are able to reduce on the expenditure that would have gone to address some of those issues. So some of the preventable issues are addressed along those feedback mechanisms. We also have a platform at national level that looks at districts where we give feedback and accountability, and I think most of us here in health have been part of it, which is the National Teenage Surveillance Platform. And so these accountability mechanisms are helping us to improve service delivery, reduce on the expenditure, but also come up with effective health outcomes. Instead of looking at only curative methods, we are also looking at the preventive methods and trying to front them to ensure that we reduce on the expenditure, because the money is not there that we are going to spend. We all know the budget that we have. We all know the commitment that our government has towards health financing. So one of the strategies is to ensure that we promote the preventive mechanisms on expenditure. And lastly is promotion of transparency. You know, when we engage these health facilities at district level, most of them have notice boards, but you go to the notice board, there is no budget, there is no expenditure that they have done for that period. And this is one of the things that has been creating havoc between the governance structure of the health facility and the management structure. The HUMICS will be complaining, we don't know where the money goes, how it comes in, how much we get. But with the transparency from the management, they are able to share, this is the amount of money we have got this quarter, we have used it like this and this, and we still have these challenges. So let's plan for the next for the next financing period. We have seen that this has helped to improve service delivery at the health facilities. We are seeing the HUMICS also getting engaged in the budget advocacy processes right from sub-county level, trying to front the needs of the communities and trying to share what should be done to ensure that we improve the health outcomes within the different communities that we come from. Thank you.
Thank you very much, Edith. I want to request Luke Twesigye to pick it up from there on enhancement.
Thank you very much, moderator and colleagues. My name is Luke Twesigye. I work with Straight Talk Foundation. I coordinate a project called SRHR for All that basically looks at advocacy, but also advancing gender equality, targeting girls, women, young people with disabilities, as well as men. But also Connect Men Engage Uganda, where we bring on board engagements that have to do with men and boys to also address gender inequalities. So, since morning, we have been talking about community-led healthcare financing systems and how we can strengthen them. And what I've been talking about is basically a model of healthcare financing, where community members pool their resources to provide protection against health-related expenses. And I think with regards to our country, this is where it is best fit, because we are in a low-developing country where we don't have resources, and therefore we have to put in place or to use whatever we have at our presence. And to achieve this, of course, we must we must understand that it actually requires careful planning, stakeholders engagement, but also adaptation to the local context. Whatever I've been talking about since morning, we need to really bring down to the common man just there in our communities, in our villages. We've been talking about policies, I've been talking legal frameworks, I've been talking about the Maputo Protocol, but do our people in the communities where we come from understand them? If they don't understand them, what are we doing as stakeholders who know and understand what is happening? So, as Straight Talk Foundation, we have done a lot about strengthening health systems. Because for us, we work with young people, and basically we focus in the school. Our focus is in the schools, communities, targeting, of course, the gatekeepers of young people. And what we do is that we're being, like Sahad, colleague from Sahad mentioned, we know we have different stakeholders who are actually gatekeepers of these young people, and you cannot engage any young person without having these other people understand what is happening and how they can really support these young people. So we've been engaging everyone, health workers, community leaders, religious leaders, cultural leaders, and of course different departments and structures of government, to make sure that actually what we talk about, we should walk the talk. If you establish structures in communities like VHTs and queues, and people in communities don't understand them, they don't know what they do or what they're doing in their communities, of course, at the end of the day, this service cannot be improved, or they may not even go for these services. So we have been trying to engage everyone in communities. We have been trying to, we have established structures, we have established clubs for young people, we have clubs for men who are working with boys to champion and create environment that's supportive for young people to be able to access and utilize services. Of course, I mean youth-friendly services. And in doing all this, we have actually been able to interact with young people, and they always tell us, yes, we know you have talked about these services that we can access from our facilities, but these facilities are actually, they are far from us. But even when you go there and we access them, some of them, they need a cost. So what do we do? And I've been able to, through clubs, I've been able to empower them, called Upship methodology, where we've been able to bring young people on board, including men in communities and women, and capacitate them in Upship methodology, where we empower them to identify problems in their community, social-related problems in their communities. Of course, after identifying them, we help them understand and be able to grade them and come up with one or two problems that they think they can address. And as they address it, they must use the available resources in their communities. And at the end of the day, they should be able to make money out of this intervention. So they always use this money, they plow it into their clubs, into their saving system, so that if a young person wants to access a service from maybe a health facility that is some distance, or gets a health complication, they have been getting this money from the clubs and support this young person to go and access services. And we also have established linkage networks, like she mentioned, where we engage these young people online. Whatever they do, they report to us, also engage them immediately, and actually help them to refer. If you need a service, maybe it's supposed to be provided by CDO or a health worker or a registered leader X, we tell them, go to this point and get the service. So, strengthening health care systems and provision and services, we need to work as a team. All of us are here. We come from different organizations. Of course, we work on different programs. We could be having different targets and indicators. By the end of the day, we're working in the same community almost. You can go to a district and find there are 10 partners, but each partner is doing their own part. So when we come here, what we do is that we're supposed to strengthen our collaboration and partnership, so that if you have an activity in, for instance, in PG, and you have other 4 partners who are there, you can first sit and agree and say, I'm doing ABCD, you are doing ABCD. So can we put together all these resources and have all these targets we are supposed to meet at once? Because if I go there and do my work, I go away. Sahad goes, does their work, and I go away. At the end of the day, actually we are promoting some level of inequality. I'll be doing mine, maybe I'm going to facilitate VHTs very well. Then when SAD goes, maybe you're going to give them a little money. At the end of the day, they will not do the work. But if we can work together as a team, like we have signed on this board, I know some people will chicken out. This has happened on several occasions. You commit, you say I'm going to do A, B, C, D, but when you go back, you join, you form other cocoons and you find it's only one person or two people who are pushing this forward. So the only way you can really change the narrative out there is to work as teams. We form one voice. Even when we say we're going to advance this agenda, what is HIV or TB, and we are all, we have one voice. The government can listen to us. But if I'm the only person pushing it, like Madame Flavia said, we can even protest the war and so on. If I'm the only person protesting, they're going to bring tear gas. And I'll be stopped. But if we are many, we can put our point forward, advance it, and they're able to listen to us. So it is important that as we engage our communities, let's give them proper information, let them understand what they're supposed to do. Because I guess most people in the communities, they don't even understand what we mean by community-led healthcare financing. So our first key entry point is that we should make them understand actually what it is, its benefits, how they're going to benefit, who should be part, you know. But as long as we don't really engage them and make them understand what they what we are up to, the problem they are faced with, and actually when we are engaging with people in communities, they always have solutions to the problem that they are facing. So if you don't engage them and be able to understand the problems and give you solutions, of course we shall always come here, talk, commit. We say we can even have another conference next year, we shall come and do the same, by the end of the day, we shall not achieve anything. So it's important that as participants who are here, we enhance partnerships and collaborations and work together going forward. Thank you.
Thank you very much, Luke Twesigye from Men Engage and Straight Talk Foundation. Yes, Don Ndazima, you've been part of the conversations since morning, and all the discussion is centered around strengthening community health financing systems. So from your view of point, what are we not doing well, or what do we need to do better, and what resources do we need to do this? Thank you.
Thank you, Karim. As introduced, I'm Donny Silas Ndazima from World Vision, Uganda. What resources? Yeah, we need really financial resources, and I would appreciate government and Ministry of Health specifically. They managed to lobby and managed to increase the health budget to 9.964 billion in the FY 2024-2025. You would realize that they got an increase 422.8 in that FY, and that was an increase from 9,541.7 billion. So that is really a remarkable increase. We need these resources, as we stipulated in the Abuja Declaration of getting to 15% in 2001. But we would appreciate that it's not possible for Uganda to get to the 15% as we stipulated. You would realize that always we are lingering between 9, 8, we are always below 10. So I think this was a commitment that was just made to appease the international community, but we are not walking that talk. And ideally, we should appreciate the global challenges after Uganda coming up with the Anti-Homosexuality Act. You'd realize that we've gotten donor cards, and a lot of, many of the World Bank funds that we are getting, those grants, we've had a reduction that we should appreciate, but that's the choice that Uganda decided to take, and we should appreciate that. So ideally, as World Vision, after realizing that we can't get the required resources, we've decided to strengthen community structures, and we are working with village health teams and the community health extension workers, they choose. And we believe that we need to digitize the systems. We need to have the electronic community health information system, and this is currently running, and I really appreciate MOH. This is running, but you realize that it's only in 20 districts currently, just in 20. So when you compare this with the number of districts that we have in the country, you see that there is a very big gap. But of course, it is a very good step because it has enhanced reporting. But also, we have managed to strengthen the electronic registry information system so that you are able to have on-spot data reporting. You are able to know who is working, which village health teams are working, they are working on what are the outputs. That is something commendable. But ideally, what resources do we need? We need human resources, and I believe that we, in this room, we are the resources that Uganda needs to improve health, and we should realize that health starts at home, in our homes. But you realize that in Uganda, we've not got it to the 100%. Zero defecation. We still have open defecation. So some people do not use toilets, they do not have toilets. So we have not really got to free open defecation. And in that sense, some of us do not have basic sanitation in their homes, just basic sanitation, a basic toilet, based on its indicators. Some households do not have that. So even if we get the 15% as stipulated in the Abuja Declaration, when you do not have that mindset change, the resources will not help. So I was very much happy with NDP 3, which had the component of mindset change. And in NDP 4, they are thinking of getting it into the human capital development, which I believe is quite good, because people need to have that behavior change communication to appreciate that I need basic sanitation, I need the minimum health care package. So without that, and people appreciating that we need it, we can't improve our health indicators. But I would like to note that Ministry of Health has done a commendable job, and if you looked at the indicators on maternal mortality, infant mortality, neonatal mortality, but also wash coverage, hand washing, there is an improvement, but you could do better. You need to realize that Rwanda is doing better than us, and they've done very well on eradication of diarrhea, and they've declared that they are free. For them, they do not have any episodes of diarrhea. They've really done away with it. But for us here, we are still struggling. So I believe that the resources that we need, we have them. Even in this room, we have them. But what we need is the mindset change. Mindset change, behavioral communication. But ideally, it's also true that the funding to community health is still quite limited. Despite the increase in the entire health budget, the funding is still limited. There we need to do some work, but the resources will never be enough. Like for Uganda, the resources will never be enough because the largest part of our budget is donor funded. And that means that we are all struggling for those meager resources. And because of that, we need innovative ways. And innovatively, we need to tap into social protection. For instance, the Youth Livelihood Program, we have the SAGE funds. How can we innovatively use these funds to improve health outcomes? There is a report that has just been published by Makerere University about the Youth Livelihood Funds, and it has very intriguing findings, highlighting that these funds are not being used to the right cause. The beneficiaries were not well oriented about the purpose of these funds, and ideally they are just eating them. I have a brother who got into a group, he got that money, and he just ate it, my brother. So that is how these funds are used. Thank you for now.